Hello, welcome everyone to Grand Rounds. Today I have the pleasure and opportunity to introduce one of our own and finest interventional cardiologists, Dr. Selwyn Abraham. Dr. Abraham graduated from Loma Linda University, went on to do his training at Baylor University, and was recruited to Tennova Hospital to take on and start their cardiac program there. He was there for 7 years. Led a really robust group of individuals there, at which point we recruited him to Erlanger to join our interventional cardiology group, and also has taken on the start of the cardiogenic shock program. So I welcome him today to talk about functional coronary artery disease more than meets the eye. Thanks, Dr. Abraham.
Hello, good morning, everyone. It's a pleasure to be here and to speak with you today. My topic is functional coronary artery disease. It goes by actually quite a number of different names currently. It's been heard of as MINOCA, INOCA, Vasoplastic, coronary artery disease, coronary microvascular disease. It's kind of a really shotgun approach to how people are talking about it here in the past 5 years or so. But there's actually a group out there called Covidis that are coming together of thought leaders in cardiology that are really trying to make this topic shine out as it's supposed to. And this is actually the umbrella term, functional coronary artery disease, to all those other diagnoses that I just spoke about. And we'll go over that very quickly too. This is not a mainstream topic in cardiology, at least not yet. And one of the reasons is because probably only 10% of institutions in the United States even test for functional coronary artery disease. But that is changing. And one of the main reasons why that's changing is that it's because technology has advanced, and nowadays it's much easier to test for this, and people are catching on quite quickly. So it's actually basically every year there's a good robust trial coming out about functional coronary artery disease, and we're learning so much more about it. So let's see if I can work this. So I know I look like I'm Indian, but I was born in South Arkansas. So stereotypes do not fit me. Okay. Oh, no disclosures. All right. I'd just like to get to know my audience very quickly. Does anyone know what this screenshot is of? This is the only time I'll be asking you questions too. So it's pretty low key. Anybody? Very good. There's two reasons why I'm showing this. One is, who is this gentleman, Mark? Go ahead and tell me. That's very good. And what is happening in this scene? Okay, all right, very good. So this is the scene that they are teasing, that ObiWan Kenobi is just meeting Darth Vader. And this is the first time he's meeting Darth Vader, and he's heard about him. The last time he's met the real Darth Vader was Anakin, and at that time he thought he was dead, correct? So he's heard this force called Darth Vader out there. He doesn't know what it is. He just thinks it's another dark Sith Lord, but when he meets him, he senses him and he realizes that there is more than meets the eye. It's not just another dark Sith Lord. It is a combination of everything that he has, all this bad memories, the friendship, the disobedience of Yoda, right? The promise made to Qui-Gon, all of this together. It's not just one dark Sith Lord. There's so much more to it. And that's kind of why I picked this picture. And also because, as Mark mentioned, tomorrow is the start of the series. So no matter what you are doing today, whether you're collecting a patient's UA, whether you're doing an overbooked clinic, or whether you get roped into Grand Rounds, in 24 hours, a new story begins, and you can enjoy that. And so may the force be with all of you as we go through this. All right, so our objectives here is I'm going to go over the history of coronary artery disease very quickly, obstructive coronary artery disease. I have to do it very quickly just to give you the foundation of what I'm trying to go through and what I'm trying to explain. I also want to go over to how your patient can have angina and come back to you being told that they have their coronaries are wide open. Maybe some of you have sent me a patient and they're having typical angina and you're sure this is an obstructive disease. And I come back to you and say, the coronaries are wide open. There's nothing wrong with this patient. If I have, please forgive me. But there's now, I can tell you that there's other entities out there we have to be careful for and look for when we have these patients that are symptomatic. Why is it important to make the diagnosis of functional coronary artery disease? There's got to be a reason for us to look for this, and it's got to be hopefully make a big enough impact in the patient's life to actually go through the process of finding what functional coronary artery disease is, and then on whom are you going to make this diagnosis on. So, all right, really quickly, the history of coronary artery disease. So, you send me a patient. I'm going to put them in this cath lab right here, something similar to this, not exactly this, because here we have Dr. Maniam doing one of his supposedly interesting electrical studies, but I can use a similar lab to this, and I'll put a patient in there and do a heart catheterization. And as I do that, we'll start taking images of your coronary artery vessels. And once we start doing that, we can take different projections. We're seeing the coronary artery in a 2D view format. So when we're doing that, we take hopefully orthogonal views 90 degrees apart. And when we take a look at this vessel here that has atherosclerosis, if it's an eccentric plaque, if we take a look at the view from B, we would see that maybe this is just a 5% diseased artery. But if we take a look at the projection from A, we would see that it's actually 77%. So, and with this imaging that we do, we will make a determination if the stent needs to be placed. And of course, many of you know that around 70% is when we would put the stent in. Now, just me describing this process to you should have you very concerned already if this is the technique that we're using. You can imagine there's already so many pitfalls just by my description of this that will say, whoa, well, that doesn't seem a very solid basis of why we should put a stent in, because what if this projection, what if I don't get the perfect 90 perpendicular angle to show me the 77% lesion? What if my angle was just a little bit off and it actually looks like it's more like a 60% lesion or 50% lesion and I didn't get the right angle? That should be concerning to you. What if what if this is 5% in one direction and 77% in the other direction? Does that mean we take it as the 5% or the 77%? So how does this come about? So it already, I'm telling you, by the way we go about doing this, it's kind of concerning. There must be a more objective method to finding out if this lesion truly needs to be stented or not. And there is, which I'm going to show you here in just shortly. But the concerning part is probably 60 to 70% of interventional cardiologists still today use this method to determine if a stent needs to be placed in an artery. And so it's something to keep in mind as we go through the rest of these slides here. All right, so basically what we do here is that we look at the epicardial arteries. We see if there's a blockage there, and if there is a blockage, we put a stent in. And then if we put the stent in, we give ourselves a pat in the back saying we have revascularized the patient, all is well, and we go about on our way. But now that we are talking about functional coronary artery disease, we realize that there is more to it than that, and that actually the blood flow system incorporates a much more than just the epicardial vessels and epicardial flow. It has to deal with there's a much more involvement in the microvascular blood flow. This portrays kind of what I'm talking about when we are talking about the epicardial vessels. We're literally talking about this section of the coronary tree, but there's much more to it than that. There's the small arteries, arterioles, down to the capillaries, and then when you look at this part of the diagram, you can see that resistance actually is played a bigger part in the smaller arteries and even the epicardial artery. So it seems like you'd want to even care more about the smaller branches than just the bigger branches, because that's where a lot of the resistance is played in. And if you have lesions in that or dysfunction in that, you would have much more difficulties with your blood flow through your coronary tree. So functional coronary arteries now is we're trying to do a better job at describing it, kind of putting the different dysfunctions together. So we're labeling it in different ways. What I just kind of wanted to talk to you before, probably one of the most common things that we hear is about INOCA. Maybe some of you have heard of that before. That's ischemia with no obstructive coronary artery disease. These are patients that come in with angina. You do a stress test or some sort of test, stressing, non-invasive study on them. It comes back positive. You send them to the cardiac catheterization lab, and the epicardial vessels are open. And so those are the patients that we come back to you that I described before, saying coronaries are wide open. Good luck. So that is INOCA that's the terminology we're using for those patients. We have patients that come in with actual acute coronary syndrome. These are patients that come in with an elevated troponin or an abnormal EKG showing ST elevation, ST depression. We send them to the cardiac catheterization lab. We shoot their coronaries, and guess what? They're open. But they have had positive troponins, and if you study them with some sort of perfusion study, you could either see scar or some sort of event that occurred in the past. And so those are patients we will call MINOCA, MI with non-obstructive or normal epicardial coronary artery disease. Then we have the coronary microvascular dysfunction, slow flow syndrome, no reflow syndrome, Takotsubo cardiomyopathy that kind of fits into that category. And then, of course, you have epicardial vasospasm, microvascular vasospasm, and then lastly, a myocardial bridge where you actually have epicardial arteries that will kind of dip down into the myocardium and actually get compressed during contraction. And so that's a whole nother entity in and of itself. So in order to be able to speak about this with each other, with our colleagues a little easier, we've decided to, the team has decided to start making them called in different types. And so the functional coronary artery disease will be now defined in about 5 different types. And so when we're talking about type 1, we're talking about what my talk is about today, primary microvascular disease in the absence of underlying myocardial or obstructive disease. Type 2 is this type of disease that also has been portrayed in hypertrophic cardiomyopathy or hypertensive coronary artery disease. Type 3 is your ACS patients, patients that have either obstructive lesions from stable coronary angina or acute coronary syndrome. And type 4 is your disease that occurred due to some trauma that that your interventional cardiologist would have done. And then, of course, type 5 is CMD that occurs in cardiac transplant. Okay, so how do we make this diagnosis of functional coronary artery disease? It all started with coronary flow reserve. And what coronary flow reserve is basically a ratio between the highest amount of flow you can produce through a vasculature over the baseline resting flow that usually occurs. And so if you put those ratios together, you'll get coronary flow reserve. Usually the normal ratio is greater than 2, sometimes 3 to 5. But basically what that'll tell me is the entire flow through this system, all the way from the epicardial system, all the way to the microvasculature. The only issue is with this value is that if there's anything wrong anywhere in the system, the value will be abnormal. So you wouldn't be able to differentiate if it's epicardial or if it's in the microcirculation, but it does tell you, the value does tell you that there is an issue with the system, the capillary or the coronary system. And so how do we make this diagnosis? Now, this is an equation that all of us have seen once upon a time. We can't get into medicine without being able to having to at least taking a look at this equation. Flow is equal to difference in pressure over resistance. So what happened was back in 1974, Dr. Gould, he did this study where he would take a dog into a lab and he would put a ligature on the coronary artery, and he would basically constrict that ligature tighter and tighter. And he finally decided that he ended up finding out that around 70%, you would have a decrease in the maximal flow of the vasculature. And once that the tightness goes around 90-95%, you would actually have a decrease in the resting state of it too. So this is where the original concept of a 70% lesion probably needs to be stented. The idea was that if you have a coronary flow reduction of around 70%, you would start having lack of blood flow. It probably is a good idea to put the stent in at that time. Now, that seems like a very simplified way of treating this equation, but it is not that easy. I wish it was Q equals P over R, but it's not. In fact, when you actually look at the equation of what actually goes into flow through a coronary artery, the equation all of a sudden becomes something like this. And it makes sense because you have flow is related to a coefficient of friction. And then flow is also has to be related to a coefficient of separation, which means that the length of the stenosis, the actually diameter of the distal vessel, plays a role into what actual pressure drop that occurs over the stenosis. So you can't just say that you have a stenosis here and that equals this form of a pressure drop, therefore it's significant. This was proved by two different studies. This is the original study that Dr. Gould did. He said that once a flow hits a certain amount of decrease, you'll have an X amount of diameter stenosis. But that's great. But if you flip the question around and you say, well, what if I look at patients with these stenosises? Will I get correct some sort of flow that makes sense? But you don't. It has it's a scattered graph, and that makes sense because if you're using coronary flow reserve, as we mentioned, it's a variable number. If your baseline changes, if your heart rate increases, if you have increased contractility, their baseline flow changes. Therefore, CFR is not a consistent number that you can use. But because of this original study, that idea of 70% disease, 70% decreased flow rate is a 70% lesion. Therefore, that's when the stenting needs to be done. So more studies took place. We had to find a way to make this work for us so we could have a more objective number. So basically, we found out that physiology can predict stenosis, but stenosis will not predict your physiology. And that's to make it simple, what I'm trying to say. So CFR had its problems. We had it affected by resting hemodynamics, as I mentioned. There's no defined normals. I mean, you can imagine a guy like me, I have an elevated but resting heart rate, out of shape. My numbers must be much more different than a guy like Dr. Maniam here, who's, of course, in his peak health. His resting indices must be much better than mine. So therefore, you can't compare apples to oranges, and that made it difficult. Like I mentioned before, the measurement of the coronary vasculature is in its entirety with the CFR. You can't tell if it's an epicardial issue or it's a microvascular issue that you're dealing with. And of course, previously, it was very technically difficult to measure CFR. You would have to use this thing called a Doppler wire, which basically went out of fashion right when I left. Some of my colleagues have used it before as I was speaking with them. It was very well known to have a 60 to 70% chance of being right, a 30 to 40% chance of being wrong if you did it wrong, technically. So it was just a very difficult thing to do a coronary flow evaluation on these patients. So what do we do now? So how do we make this make sense? How do we get an objective measure of what we're doing with the epicardial section of the coronary artery tree? So I just told you that each lesion is basically its own. It lives on its own curve. So it's hard to use that as a measure of objective evaluation, but you can look at this curve and you can see that at a part of its section that this curve becomes linear. And when the curve becomes linear, you'll then know that, or you can then induce that a change in pressure will also increase the same amount of units in the change in flow. So therefore, if you have a hyperemic vessel, if you induce hyperemia, which we do with adenosine, we increase the maximal flow. If you determine a change in pressure, you have determined that same change in the percentage of flow. And so we use that now as our objective measure. And that's just basically showing what we just discussed. So now we can use the same equation, Q equals P over R, and make it a little bit easier in that if we take the flow distal to a stenosis over the flow proximal to the stenosis and you put it over each other and make it a ratio, your resistances cancel out because you're talking about the same artery, the same vascular bed. So then that would mean that your QS over QN is equal to the pressure distally over the pressure proximally. And so once we had that piece of information, we call that FFR. And we said that PD or PA at hyperemia is your percent of reduced flow in that arterial bed. So just to show you what we do in real time, we find a blockage, we put a wire across, and this wire has two sensors on it, one distally, one proximally. This is measuring the pressure distally, this is measuring the pressure proximally, and you have a ratio of FFR during maximal hyperemia. We increase the flow by using adenosine. So now we have to validate this. We got this idea. We want to validate it and make sure that what we're talking about is correct and it works really well. And I'll just spend a few minutes on this just to show you, to give you confidence that what we're doing in the lab now is correct and we have good outcomes from it. So there's a study that was done, measurement of fractional flow reserve to assess functional severity of coronary artery stenosis. This has occurred around the 90s. I think it's early 90s. Dr. Nico Piles did it. And this is an amazing piece of work. And honestly, as the amount of work he put into this and what he showed from it, basically what you would have is patients would come in, they would have each patient would have three different forms of stress tests done. They would have an exercise stress test done. They would have a thallium scan done, and then an echocardiogram, echo stress done. Three different forms of stress done. They would then take them to the cath lab. Of course, these patients would be evaluated for one vessel disease. You take them to the cath lab, they find the lesion, they'll do an FFR on the lesion, they'll get that number, they'll fix the lesion, they'll re-FFR it after fixing it, get that number, and then after that, they will run them through the same three stress tests again to make sure that they have a good validity of what they're doing and making sure the numbers are bulk and is standing on a good foundation. What they found out is that if you pick the number 0.75 and less, all these patients would have an abnormal stress test, and all of them, after you fix them, would have a normal stress test afterwards. They use the number 0.75 as what is a cutoff for abnormal. With this, you had an 88% sensitivity, 100% specificity in determining if a lesion was significant or not. Now, after this was done, there's probably a minimum of 20 different other randomized controlled trials done on this number, and they all came back showing that this is it. This is very strong. They use different methods, MRIs, PET scans, different other methods to see which if this still held up, and it did hold up. The only difference that we made on it now is that we changed it to 0.8 instead of 0.75. The only reason why is they did some calculation. They found out that by doing that, we would increase our sensitivity with minimal effect on the specificity. So now, as a clinician, we all say that 0.8 is what we're going to use for our number to make sure we catch everybody who has obstructive lesions. Now, we came up with a number. We showed that we could pick out an obstructive lesion with the help of non-invasive testing. But what does that do clinically? And just very quickly, I want to show you this trial called the FAME trial. And this was also a great study that was done. And basically, patients came into the cardiac catheterization lab. They had their coronary angiography done. It was determined that this lesion needed to be stented by the interventional cardiologist. And then they were randomized to one or two groups. One is they went ahead and fixed it, what the original plan was. The next group would have an FFR done. And that FFR, if it was less than 0.8, they would fix it. But if it wasn't, they would let it go. And they would have those patients just follow up, and they would watch these two groups and see how they did. And what they found was pretty astonishing. Basically, those that were angiographic guided PCI had greater rates of MACE, and the FFR guided PCI had really good. They did much better. And what really was interesting is that the survival-free myocardial infarction was the main driver of MACE that made these patients do worse. So essentially, what I'm saying is that these patients that go in and you put a stent in these patients that have a normal FFR, you're actually causing what you're trying not to cause. So they would cause increased chances of heart attack. You'd cause increased target vascular revascularization. So that really put a light on things and try to kind of shove everything to like that. Hey, we need a more definitive way, more objective way to determine our epicardial system and if a patient needs to have stents or not. Okay, so I just talked to you about the epicardial system and how we can determine if the flow in the epicardial system is objectively correct. So that has been taken care of. But now we realize that, hey, we have this method for the epicardial system. What about everything else? Can we make this picture whole? So this is what we talked about. We said of this CFR talks about the entire system as a whole. If the flow is okay, if you have a normal CFR, usually you can say your flow through the entire system is normal. But if you have an abnormal CFR, you don't know if it's epicardial or microvasculature. We created FFR. Now we can tell you objectively if the epicardial flow is good or not. Now all we have to do is work on this IMR part, which is the index of microvascular resistance. And so if we can figure out that the microcirculation is good objectively, then we'll have kind of a whole picture of our coronary vasculature. So how would we do something like that? Well, kind of like I mentioned before, we have this wire, right? This wire here that has a sensor distally and a sensor proximally, which would check pressure. However, there is this wire that has come out by Abbott, and I'm not Abbott fan. I'm not promoting it or anything. It just happens to be the only wire we have available in the entire market that actually has a thermistor also right where the pressure sensor is, distally and proximally. With those two components, what we can do is something pretty neat, which I'm sure all of you have heard before. Is basically like doing a right heart catheterization, getting cardiac outputs. What we would do is we would inject cold saline or room temperature saline, and this thermistor would calculate the time it takes from the proximal, from the temperature change from the proximal port to the distal port. With that, we can calculate a mean transit time. And so once we have mean transit time, everything else with the flow, with that, which it tells us what the flow is, everything else becomes easy from that. So flow equals pressure gradient over resistance. Flow is Q, which is flow, is equal to 1 over your mean mean transition time, which is this right here. So now all you have to do is figure out the pressure gradient. So you have to know what the pressure is before the small vessels, subtract the pressure after the small vessels, and then you would have a pressure gradient. So we would say PD, that sensor on the distal tip of the FFR wire will tell us what our PD is. PV is the pressure in the venous system in the heart, but however that is so negligible and small, we'll call it 0. So basically PD would be your pressure gradient, and that is over resistance. So then if you just solve for capillary resistance, you have PD over 1 over your mean transitional time. So that would give you your index of microvascular resistance, and anything over 25 is what we would consider abnormal. This is just another diagram showing you what I'm trying to describe. Here's your capillary bed right here. We find out what the pressure is on this side of the capillary bed from our wire. We have pressure that we're going to assume is 0. Venous pressure is 0. We have our flow now because of that transistor told us the flow because of 2 thermistor on the wire. And so therefore now we can calculate for your index of microvascular resistance. And this is what it looks like in real time. If we were to do a case, you'd shoot your coronaries, this is what a coronary angiogram would look like. You put a wire through it, and while you're putting the wire through it, you will give the adenosine. When you give the adenosine, the machine basically does everything else. It calculates your FFR, which is 0.93, which is normal because we said anything above 0.8 is normal. We calculate your CFR. Your CFR is 2, which we said anything less than 2.5 is abnormal. So you know there's something wrong in this vascular bed already. And then, of course, you have your IMR here, which is 55, which is greater than 25. So you would know that this person has microvascular disease. And so that you can make the diagnosis this way. Okay, so that's how we dealt with the microvascular issue of the coronary bed. There's few other entities out there we just have to remember about also. Vasospastic disease. These are patients that have arteries that will clamp down and spontaneously and cause chest pain, which is also can affect your patients. So just really quickly, vasospastic angina was described by Dr. Prinzmetal in 1959. There were patients with rest angina that would have ST elevation that responded to nitroglycerin. He would see these patients and he would just describe these episodes of chest discomfort, which happened to be then called Prinzmetal angina. Shortly afterwards, cardiac catheterizations were started to be done, and they would reveal these spontaneous attack of spasms that would occur with both ST elevation and depression. And if you would give them nitroglycerin, these attacks would go away. And then later on, we found out that acetylcholine testing would cause ST depression. And sometimes these patients would have no changes in their coronary angiogram, but yet would have EKG changes and symptoms. These patients, we would say the microvasculature is now spasming. That's likely the cause of it. And so this is how we differentiate vasospastic angina in these patients. So things about vasospastic angina to realize is that it can be very variable. It can be focal. It can be diffuse. It can be multifocal. It can occur in one vessel. It can occur in many vessels. It can fluctuate, depending on the patient. The sites that it can occur, it can be at normal coronary arteries, or it can be at stenotic lesions. It happens in younger patients with fewer coronary artery disease risk factors. And sometimes you would think that these patients have issues with hypertension and either a high heart rate, but that's not always the case. It does not have to be preceded with that. These can happen in just normal people with normal vitals. The issue with vasospastic angina is that we just don't know the prevalence of it yet. It's still not systematically evaluated in our core cardiac catheterization lab. The problem is that currently there's no real protocol we have that everyone has agreed upon to determine if there is vasospastic angina or not. The variations, the definition still varies between a 75% constriction versus 90% constriction, depending on the acetylcholine challenge. The United States is absolutely lowest for evaluating for vasospastic angina, and of course the highest is Japan. All right, so for the diagnosis of vasospastic angina, you need a few things. You have to have at least one of these. You have to have a rest angina, especially at night and early in the morning due to likely cortisol surge that occurs, a diurnal variation in exercise tolerance, and hyperventilation can sometimes precipitate the episode. And then, of course, calcium channel blocker suppression. You have to have at least one of these things that are occurring, and then you have to have a documented ST change that occurs, either ST elevation or depression or some sort of U wave that you see. Or you can have a documented inducible coronary artery vasospasm on cardiac catheterization. And everyone is now leaning towards 90% constriction being the number that you have to hit to make the diagnosis of vasospastic angina during cardiac catheterization. And then if you wanted to evaluate for vasospastic angina in the cardiac catheterization lab, this is honestly part of probably why it has not caught on. You can see just by showing you this slide, it is quite involved and takes time to do. And then, of course, another issue is funding and billing for it. So you're asking your doctor to perform an time-consuming test with minimal reimbursement for it. So we believe that's one of the reasons why we're having issues in the United States to help get these diagnoses done, but there is a push towards changing this. But just really quickly, just going through the protocol, we'd first start with adenosine to cause hyperemia. Once we do that, we'll get our FFRs, CFR, IMRs I walked through on that other slide. Would also test for nociception evaluation. Sometimes patients have adenosine hypersensitivity. We would be able to test for that while we're giving the adenosine. Once that's done, we would stop the adenosine and start doing acetylcholine testing. And this is what a usual protocol will look like. We'll start with low dose and evaluate the coronary tree. And then we start going up to a higher dose to all the way up to a spasm dose to see if we can induce 90% contraction during our high dose acetylcholine. And then, of course, once this is all done, to abolish spasm, we would give nitroglycerin to see if we can reduce it or make it go away. I have to admit, when you're hearing something like this, you have to be concerned about complications that can occur, because you're basically shutting down a vessel when you're testing for this. So in a potentially person that could be normal. So you have to really consider that when you're going into this. But fortunately, we've done quite a bit of studies from the few centers that we have, showing that this can be done on a very safe way. There's certain techniques you would use, like I mentioned, the increased dose slowly through the process. The next thing is we'd put a microcatheter down, just one vessel. So make sure we test one vessel at a time as we do this. And to see if we can induce vasospasm. And so that way we don't have the whole coronary tree go out. Sometimes this was done IV, and of course you can imagine what kind of issues that caused when you have diffuse spasm all over the coronary tree. Patient would go into shock, and then, of course, things would go bad once that occurs. So this is why we try to do it more on a one vessel basis as we test for vasospastic angina. Okay, so why is functional coronary artery disease important after going through all this? So we learned how to do it. Why would we do it now? So, it's associated with adverse outcomes. There's the WISE study that was done all the way back in 2000 that showed that patients with evidence of microvascular disease have increased rates of MI, CHF, arrhythmias, stroke, and death. The burden on the healthcare system is serious. We've all dealt with patients in the ER that has come through multiple admissions, multiple cardiac catheterizations, promising to you that they're having angina, that something is wrong, but you can just keep telling them that your arteries are opened, go see your GI doctor, go see your pulmonary doctor, go see your psychiatrist, when they actually have an actual pathologic disease that's giving them problems. Of course, this then increases your burden of anxiety, depression in your patients, and just the fact of helping your patients from a symptom standpoint, making them feel better, that should be a good enough reason in and of itself to test for this kind of pathology. I still remember when I was a cardiology fellow, I was rounding with one of my attendings, and my attendings would just keep boasting that if you put a stent in a patient, there's been no studies that show that it saves a life, that all it really does is prevent angina, is what putting stents in patients do. And then I had to ask him, well, let's just pretend you had a knife sticking out of your leg. Of course, you're hurting from it, but what if I tell you that I'll just treat it with alcohol, betadine, and we won't remove the knife, we'll just let it stay there, and your mortality will be the same. I'll make sure it's clean, I'll make sure everything looks great, and you just continue on as you are. You would never say something like that to a patient. They're hurting, they have symptoms, you want to make them feel better. That's their life, their perspective that you want to really respect and get them feeling better. So even if the best thing we can do is reduce pain from a diagnosis, I think that in of itself is worth trying to do. Okay, so I want to just go over one trial that has finally come out that is randomized controlled, that shows how beneficial it is to diagnose and make this diagnosis of coronary microvascular disease. So this is called the CoreMICA trial, stratified medical therapy using invasive coronary function testing in angina. It's a very interesting study. The patients that came in saw their doctor and decided that they needed a heart catheterization because of their angina, because of stress testing, for whatever reason they were brought into the cath lab and they were stratified and put into the study there. They would make a deal with them. Basically, what would happen is if they had an abnormal cardiac catheterization, stent needed to be placed in, they would not be put into the trial. However, If they did not need a stent and the coronaries were open, they would evaluate these patients for small vessel disease, and they would stratify them into two arms. They would do one arm where half of them would be put through the test, and they would have the result been given to them, and they would be treated according to that result. The next arm was very interesting in that the interventional cardiologist would be then asked to leave the room, and another interventional cardiologist would come in. They would perform the test on the patient, find the diagnosis, but would not tell the cardiologist taking care of them what it was. And they were to find out, treat them as you would, just like we would do with our patients now. We would come in, doc, I'm having angina. You come in, you have normal coronaries. You say, oh, you have normal coronaries, make your diagnosis and have them sent on their way. So they looked at these two arms and decided to see how they did. They used a Seattle Angina questionnaire to determine burden of angina, frequency of angina, quality of life, all of that into this questionnaire. Higher the score, the better. And they looked at it 6 months later to decide what were the results. This is really quickly. I know you probably can't even see anything here, but just to show that what the baseline population looked like. And all I really wanted to point out was it's just very interesting that 75% of the patients were female, and it was a very young crowd. It was in the 60s that would be enrolled into the study. So what we found out that if you looked at the intervention group who got the diagnosis, got purposeful treatment for the diagnosis, they did much better than the patients who were in the control, who were being basically treated as we're treating them now in 90% of centers. They would just get a pat on the back and have them go on their way. But you would have a difference of 11 units, 14, and 9 units. And basically, 9 units is equal to 1 Canadian CCS class anginal equivalent. So basically, if you had a patient who had chest pain with moderate exertion, you would now decrease them to having a functional life with minimal anginal episodes throughout the month. So basically a significant improvement in anginal quality. If you get those who were in the interventional arm had a significant improvement in anginal quality, which was very eye-opening for the community, cardiology community, when we saw this, to show that we can make these patients feel better if we treat them correctly. Also, what is interesting is that 50% of the patients who originally came in had a change in diagnosis from what they had originally thought it might be to what it is. And 36% of patients in the control group were given a wrong diagnosis. So 1/3 of the patients that had open coronary artery disease with chest pain and did not have any functional evaluation, 1/3 of them would be given the wrong diagnosis, wrong medicines, and sent on their way, which is interesting to see. Okay, so who should we test for dysfunctional coronary artery disease? Patients that come in with your typical angina, they have an abnormal cardiovascular testing, and you cath them with, and they have no epicardial obstruction. These are the patients you want to have evaluated for functional coronary artery disease. Anyone with repeat ACS admissions that continue to keep having these normal coronary angiographies. When you do angiography, if you have a slow TIMI count, a TIMI frame count, you might want to think about that in evaluating for microvascular disease. And of course, Takotsubo cardiomyopathy has also been thought of possibly being all due to small microvascular issues that's causing the LV dysfunction. So these are the kind of the baseline of what we're decided of what we should do for testing for the patients. There are trials going on currently right now to determine if this is the right group to get, but it looks like we're headed the right direction. So okay, how do we treat these patients? Vasospastic angina, how are we going to treat these patients? Aerobic exercise is important, as it is with regular good old-fashioned obstructive coronary artery disease, just as good as it is with peripheral vascular disease. Aerobic exercise is excellent. It creates a new network, angiogenesis. It helps your patient. Magnesium supplementation, if it's alcohol-related vasospastic angina. Calcium channel blockade. Of course, we think a majority will respond to calcium channel blockades, and it's also okay to use 2 different types of your calcium channel blockers to help these patients. You want to avoid low concentration at night or early morning, because that's when they usually get the vasospastic symptoms due to the cortisol surge and all that. If you have patients with coronary artery disease, usually there was a thought process. If you have vasospastic angina, you do not want to use beta blockers, but we've decided that it's more important to treat the CAD, and you could use the beta blockers, but just try to avoid the non-selective ones such as propranolol, which we usually do anyway. Okay, microvascular dysfunction, the treatment for that is usually something like ranolazine, lifestyle changes. These are patients that have low CFR, high IMR with adenosine that we went over. Endothelial dysfunction, we usually treat that with beta blockers, ACE inhibitors, statin, lifestyle changes, and then of course adenosine hypersensitivity, increased nociception, we treat that with caffeine, beta blockers, or imipramine. Now, the honest truth is, like I mentioned, the wheel has just begun to turn with this dysfunction, and that the treatments are not yet evaluated by randomized trials just yet. That's going on currently. But this is currently the thought process of what likely helps these patients. Some proposed targeted therapy that we're using now and why we use it: statins, they reduce vascular inflammation. Beta blockers, specifically nebivolol, we have some idea that maybe this specific beta blocker is really helpful in improving endothelial function and reducing the symptoms in patients with increased CFR. ACE inhibitors, metformin, also even in non-diabetics, are kind of hopeful in that it improves microvascular endothelial dysfunction. SSRIs, and also theophylline for adenosine blockade in patients with increased sensitivity to adenosine. So in conclusion, just real quickly, I want to make sure that one of the main things I want to hit on is that eyeballing a lesion should be rarely done now. Usually if you have a patient, of course, if those with the 99% blockages, the 95% blockages, which is obvious without a doubt, those you probably don't have to go through any functional testing, but anything 70% or around, it should be evaluated functionally. Presentation of functional coronary artery disease vary from stable angina to acute MI. If it sounds like angina and you have objective evidence of ischemia, you should probably consider functional coronary artery disease as an assessment. And of course, currently there are randomized controlled trials that are ongoing and that are needed to test the different specific therapies of coronary microvascular disease. So, all right, that's it. Thank you very much. If any questions, I'll be glad to take them. Yes.
Thanks so much for bringing up that.
Oh,
Great talk.
no problem.
How do you think the CoreMICA trial, 2019 came out, was a big trial, and there was a lot of publicity about it, especially locally, got a lot of publicity. Do you think that has any input into what we do today, or?
Yeah, so the ischemia trial has a lot of, it does play a factor into what we think about how we treat patients with coronary artery disease in the epicardial world. That is complete, and still there is, you have people on both sides of the court on that one to determine, like, what, is non-invasive testing even worth it? Should that even be done? Should it not be done? But this, I want to make sure we understand, is like a whole different animal that we have not understood currently, and that doesn't really, we haven't had any real objective large trials looking at microvascular disease and how it plays into the whole system. And that might change everything of what we even think about the ischemia trial and all our previous trials, because we only looked at epicardial disease on them and we didn't even look at microvascular disease. So we're wondering, the thought process is with this Covadis group, that they're thinking that there's a chance that everything could turn upside down once we start getting the actual data in for these patients, and when we test the entire microvasculature and not just treat the epicardial disease. So that's a good question. I mean, we'll have to see how things come forward when we look at the entire system. Yes. Sure. Very good question. That's such a great. I should have been more honest and upright. I am an interventional cardiologist, so I did just talk about the invasive way of how to figure this out. But you're absolutely correct. On the horizon, there are PET scans, there are MRI and CT able ways to be able to test for coronary flow reserve, for FFR, and therefore IMR should be able to be done non-invasively. Now, those are not proven yet as this is, but I am almost assured that in a short amount of time they're going to have that figured out also. And then the only question is going to be is these patients that come in with obstructive lesions that you put stents in, you might as well test them for microvascular disease while you're right there in the cath lab, rather than send them through another study, through a non-invasive study. Again, while you're in there, it's all in the same cost currently. It's all in the same cost bundle. You can just do the test right there and have it there answer if they have both epicardial and microvascular disease. So those patients, I think, will always have to go through an invasive evaluation. But there is definitely, once the billing issues get settled, a non-invasive way to find out this information is on the horizon. Correct. Very high, very likely. In fact, the numbers currently from observational evaluation is up to 60 to 70% will have both. If you have, and that makes sense, obviously. If you have disease in one territory, you're going to have disease in the other territory also. So that's what I was kind of alluding to, Dr. Maniam, that things could probably turn around and go a different direction in the next 5 years when we realize that there's a whole section of the vasculature we just have never looked at. So thank you guys so much. Appreciate your time. Thanks, man. Huh? That's good. Yeah, whatever. Got it over with.
That was very nice.
You think so?
That was great. I went over FFR again.
Whatever, man.
It's good. Yeah, I did this.